But today, for the audience, we have two spectacular epidemiologists. So glad to hear that they're actually working together. You know, it might be just news to me and everybody else knows, but on the problem of cancer in HIV affected individuals. So today we have Joshu. Dr. Joshu is a member of the faculty in epidemiology and oncology, and she has a couple of other titles too here. So she works with, or maybe it's an appointment in the Welch Center for Prevention, Epidemiology, and Clinical Research, and a member of the George Comstock Center for Public Health Research and Prevention. And the thing that strikes me most is she's the Martin Abeloff Scholar in Training. And so all of us who know Martin Abeloff, who knew Martin Abeloff, are just so pleased to be able to continue his legacy in this way. And Bryan is a member of epidemiology also, and is a biostatistician. I say that reservedly because you're in the Department of Epidemiology, so you wear both hats, and you are a member also of the Center for AIDS Research, and a center that I was not familiar with, the Environmental Influences on Child Health Outcomes, and the Data Analysis Center. So we welcome both of you to our Lunch, Learn, Link seminar, which is sponsored by the Maryland Cigarette Restitution Fund research grant at Johns Hopkins. So I understand, Bryan, you'll get us started.
Yeah, I am getting us started. So let me
share your screen.
Yep. And then I believe Corey and I will switch off in the middle. So that'll just be, you know, momentary sort of Zoom switch, which, you know, I think we're all getting used to and whatnot.
Yes.
All right.
And Corinne, when it's your turn, you can share your slides.
Okay, thank you.
Mm-hmm.
All right, so as Norma nicely introduced, I am Bryan Lau in the Department of Epidemiology. My background has primarily been in HIV research, and Corey and I, you know, we got together and started doing cancer research, and she pulled me over a little bit more towards the cancer world. I was doing a little bit beforehand, but not as much as I'm doing now with Corey. So this is just a little flavor of what's to come, I guess. All right. Apparently that's not advancing. Okay, so the goal here for today is really we're going to start off with describing the burden among people living with HIV. Most of our focus for now is going to be on breast, prostate, and colon cancer, and some of our preliminary findings and kind of where we're going. So this is just sort of an overview of sort of what we've been doing and are going to be doing. So you can start off with the cancer care continuum that I'm sure quite a few of you are aware of. You know, in terms of etiology, what are the factors that are you know, causing cancer, from environmental, genetic to infectious agents, and how can we prevent them, to detecting them, going on to diagnosis among people with HIV, as well as curative treatments and adherence, and then helping to cope with survivorship. So this is sort of our framework for how we look at about cancer that we bring over into the HIV world. There's a bunch of other care continuums in HIV, but you know, we figure why not add another one to the mix. So in terms of shared informed making decision, right? You know, the question is sort of what is sort of the diagnosis and sort of the burden of cancer among people with HIV. This was a paper that my colleague, Michael Silverberg, and I published in 2015 in Annals. You can see the two highlighted cancers here are Kaposi sarcoma and non-Hodgkin's lymphomas, which are AIDS-defining illnesses. On the x-axis is age, on the y-axis is cumulative incidence. This analysis accounts for competing risk. If you look at the different types of line types, the solid line is from 2005 to 2009, which is the most recent sort of era that this paper was dealing with. The dashed line is the 1996 to 1999, or the short dash, I should say. And the long dash line is 2000 to 2004. So you can see that cancer in terms of Kaposi sarcoma and non-Hodgkin's lymphoma decreased greatly between the 1996 to 2005, 2009. But with that sort of switch in terms of shifting burden of cancer as people living with HIV are taking their ARVs, suppressing their viral loads, and et cetera, is that we see what is going on with sort of the non-AIDS defining cancers, for instance, lung cancer. And you can see here that there's sort of an actual increase in terms of risk over this calendar period of time, such that the risk from at age 75 in 1995 1996 to 1999 was about 1.8%, and has moved up to about 3.7%. And indeed, you can see that for a lot of the different cancers, focusing again just on lung cancer for the moment, this is a paper by Hernandez Ramirez et al. In 2017, that by calendar year, you see the standardized incidence rate for against sort of the general population. You can see that cancers are at a higher rate among people living with HIV. And this is well known that people with HIV are just at higher risk for cancers in general, due to the fact of immune suppression, to a bunch of factors related to their lifestyle behaviors, such as tobacco smoking, alcohol, and et cetera. And one of the things that we saw, despite the fact that this is increasing risk, one of the interesting things we found, because we could look at it from a competing risk point of view, was that this increased risk over time is actually really not being driven by HIV per se, but as actually individuals being more likely to survive to older ages and experience cancer. Now, so, this means, in other words, it's a good thing that people are living, but now we have to take care of the fact that people are going to be obtaining new cancers at a higher rate just because they're able to live to experience it. And interestingly enough, so another paper my colleague Michael Silverberg and I published was on sort of the timing of antiretroviral treatment affecting cancer incidence. And so just to orient you, this is among people living with the HIV. They were ART naive to begin with. They had no prior cancer. They were AIDS-free, and their CD4 was between 350 and 500, and entering a clinical cohort between 1996 and 2014. So you can kind of think of this time point as them entering into HIV care. And so the question is really, what is the timing of ART in terms of start immediately within 6 months versus deferral? And for those of you that are not as quite familiar with the HIV literature, right, the whole idea in terms of when to treat individuals with antiretrovirals has shifted over the different decades. At first it was treat immediately, and then it became sort of an idea that you should probably conserve your antiretrovirals due to resistance and other things. And so don't treat until their CD4 becomes less than 350, and definitely if it's less than 200, to back to now where it is sort of treat immediately. And the reason being is a lot of our drugs that we have nowadays for treating HIV, they're much more tolerable in terms of side effects, as well as much more efficacious. And there are just many more drugs. So if drug resistance does develop, then there are other options for sort of salvage therapies. So one of the interesting things was that looking at the forest plot on the right-hand side, you can see that in terms of any cancer, that starting treatment of ARVs immediately actually showed a protective risk. But when you really start to break it down between sort of what's considered virus-related versus non-virus related, you can see that in general, non-AIDS defining cancers were generally not affected by antiretrovirals. So in other words, we're seeing a lot more in terms of the viral-related and AIDS-defining cancers that there's a protective effect because in a sense, you're maintaining somebody's immune system to be able to fight off infections. So with that becomes sort of an idea of of a shifting sort of burden of cancer among people with HIV, right? As people get treated, we see where NHL and KS sort of was the predominant burden up at the top here. As by 2030, the predicted sort of burden of cancer is going to be essentially prostate, lung cancer, followed by liver. And so you can see that definitely a lot of this has to do with the idea of shifting away from infectious related causes to more factors that are less likely due to that. And we know that already lung cancer in terms of smoking, in terms of people living with HIV have a high smoking burden. So that's contributing to a large burden of lung cancer in the HIV population. But compared to the general population, it is interesting that there are some cancers that seem to be actually at lower risk among people living with HIV. For instance, you can look at this paper by Cohort and al. In terms of prostate, breast cancer, colon, and rectal cancer. You can see that this SIR is always less than 1 with p-values of less than 0.05, right? Suggesting that overall, once you compare people living with HIV to the general population, there is a decrease, appearance of a decreased risk of actual development of these cancers. And for some of them, there are hypotheses, such as for breast and prostate, that it may be hormonal related in the sense that people with HIV, it's been shown that, or suggested that the amount of virus is actually related to have an effect on hormone levels. And so that might be a potential pathway in terms of why we might have a decreased risk, but it's still an open question in terms of this. So in terms of this, right, studies, we've suggested that compared to the general population, they may have higher incidence of lung and viral associated cancers, but lower incidence of some of the common cancers. And some of the other papers that have been suggested out in the literature is that it's not really a diagnosis that occurs at younger ages. So there's not a younger age of onset. But although lower incidence in some of these cancers, people living with HIV seem to be diagnosed at a later stage compared to either general population, and another study also showed it relative to individuals undergoing solid organ transplants, in which one would assume that, you know, that population might be a little bit more comparable due to immunosuppressive drugs. And so in terms of sort of that idea of the distribution of stage, right? So this is a study by one of my former doctoral students in terms of looking at stage of cancer by HIV status. So you can see HIV status on the left side of the bar plots versus on the right is non-HIV. And you can see the white is localized. As you get further down, it becomes more and more spread in terms of regional distance and whatnot. And so in this case, we see that the distribution of the stages, that people living with HIV are much more likely to be diagnosed at a regional stage and less likely to be diagnosed at a localized stage, right? Showing a later sort of time in terms of when individuals are actually being diagnosed with cancer. Interesting enough, also in this paper, we showed that people living with HIV also had a 13% lower cancer treatment rate versus here, and some of that was also related to CD4 level. Again, you can see this paper by Cohort et al. That, again, looking at sort of different cancers, melanoma, female breast, cervix, and prostate, you can see that there's this sort of trend that of later diagnosis in terms of when people with HIV were actually diagnosed with those cancers, right? You can see an increasing trend that stage 4, twice as likely. right? So in that terms, right, we're just not doing as good of a job in terms of identifying individuals when they are developing cancer at an earlier stage. So why might that be? So, part of this could be in terms of the role of access to care, right? Later stage of diagnosis overall. It suggests that it could be access to care for screening and diagnosis. Now, in general, people living with HIV are accessing care for their HIV care, but they may not be getting the screening that they actually need to actually identify when cancers develop. Granted, this is a population that has a high level of other comorbidities. And so there is a lot of competing challenges that providers are dealing with as they treat their HIV and other comorbidities that are ongoing in these populations. Right, but also there are other factors that people living with HIV are disproportionately having. That might affect screening. They tend to be poorer than the general population. They tend to have more cigarette smoking. There tends to be more illicit drug use. There also tends to be a lot more drinking and binge drinking. So there's a lot of other factors that may be related to not only cancer risk, but also issues in terms of going and health-seeking behaviors. Also, African Americans being the most affected by HIV also have higher non-AIDS defining cancer mortality rates than non-Hispanics and their white counterparts. All right, so they have been shown to receive less likely to receive treatment for their cancers, even after accounting for their insurance status, and show a higher cancer-specific and all-cause mortality as compared to the general population, right? So those are considerable concerns in terms of how we are going to handle cancer as we move towards the future. Here's another paper by Cohort et al. In terms of looking at sort of the association between patient HIV status and mortality. You can pick, all these different cancers. You can essentially see that they're at an increased risk of mortality. Some of them, yes, are elevated and the confidence interval may span 1, but for the most part, they're constantly elevated above 1, including the confidence interval. My doctoral student, Hopkins, also presented this at a meeting in which we looked at sort of the cause-specific mortality among 218 people living with HIV enrolled in the Johns Hopkins HIV clinical cohort and had an incident cancer between 1997 and 2014 with follow-up through 2016. You can also see that in terms of cancers, among all cancers with CD4 less than 200 versus above 200, the survival after diagnosis in terms of cause of cancer, you can see that cancer here, HIV is here, other infections, and other, chronic disease and other. And so you can definitely see a shift in terms of the mortality as one would expect with lower CD4 count, but you can definitely see that the high burden of this is among cancer causes. And if we look among these individuals and looking at sort of baseline when their cancers were actually diagnosed versus also their CD4 cell count and whether or not they experienced a CD4 decline right after or during their treatment, you can see that for the most part, even among, if we focus on these low cancer severity groups, in which we define as those really estimated to having a 5-year mortality less than 50% based upon SEER estimates on cancer type and stage, we see that there is an increased risk of all-cause mortality, and at least for those with a baseline CD4 of less than 200, that it is increased risk for cancer mortality. And why is this important in terms of sort of the idea of treatment and looking at how individuals with HIV have been treated once they were diagnosed with their cancers, we can split it up into sort of the three groups. This is CD4 groups that started with the CD4 above 500, between 350 and 500, and then those less than 200. The darker lines are those who had surgery as a treatment versus those who ended up having chemo or radiation. And you can see that there's a huge drop in CD4 cell counts initially, especially among those with chemotherapy and radiation. And what's notable is that even as we get further out from their cancer diagnosis and treatment, that their actual CD4 cell counts actually do not, for the most part, obtain the level of those who actually had surgery. Now, this is after adjusting for types of cancers and trying as best as we can. This was a smaller sample size. And so I would say this it would be really great to sort of show this in a larger sample where you could actually look at specific cancers rather than trying to lump everything together in this and take into account the different distribution of cancer types as best as we could. So what does this show? This shows, right, compared to the general population, we have a higher incidence of lung cancer and virus-related cancers, but lower incidence of some of the more general cancers. There is a potential for immune function cancer types, and hypothesized sex-steroid hormone levels could contribute to reduced breast and prostate cancer related to the viral load that people might have. In terms of prevention, right, we mentioned that people living with HIV have higher rates of some factors such as tobacco, alcohol, and other exposures like HPV and HCV. Later stage of diagnosis, there's limited studies on screening and evidence that higher colonoscopy rates for non-screening purposes, and Corey will get to that in a minute or two. And they're less likely to receive treatment after diagnosis. And some of this might be a contribution due to the CD4 at when individuals were diagnosed. And overall, the mortality of people with HIV once they're diagnosed tends to be worse than people without HIV. This last slide that I'm going to present is really a paper by Engels et al. Looking at the population attributable fraction. As you look in terms of sort of age, you can see that AIDS-defining cancers is decreasing. And you can see that also decreasing in the calendar period, right? So one might expect this, that with effective treatment of suppressing virus, that the AIDS-defining cancers will decrease overall, and we do see that. But overall, we are now seeing an increase in non-AIDS defining cancers that are contributing to the overall mortality among people with HIV. And it's suggesting, you know, there is definitely a shifting sort of cancer burden and effect of that burden in terms of mortality on people with HIV. Okay. And I think I will switch it over to Dr. Joshu. So let me stop this.
All right. Okay, so hopefully you guys can all see this. So this really brings us to the question that Bryan and I were asking, which is, you know, what can we do to inform strategies to reduce disparities in survival for people living with HIV and cancer? And so first, I'll just make a case for our Medicaid team. So a lot of the work I'm about to present is based in Medicaid. And so just to give you some context, like Bryan said, people living with HIV have a high prevalence of risk factors, including smoking and poverty and other things that we know in the general population have been associated with a reduced access to care and increased mortality for some cancers. So approximately 40% of people living with HIV in the US are covered by Medicaid. So Medicaid is mostly an income-based insurance. So people of low income can qualify for Medicaid, various entry requirements in various states. But in general, they're low income people. And in general, people are covered through the age of 64. And so this overlaps largely with the age of people living with HIV in the US. So the Medicaid population is very diverse. And importantly, it provides a comparison group of people without HIV who have similar risk profiles and similar access to care as many people who have HIV, again, in the US. And so we see this as an important complement to like existing HIV and cancer resources, maybe like NA Accord and the HIV Cancer Match Study and a lot of the other great studies out there. And so a few years ago now, I guess, we got a CFAR faculty development grant. So I received the grant and Dr. Lau was my mentor. And our goal for this grant was to evaluate the differences in screening incidence, in screening and incidence of non-AIDS defining cancers. So we specifically were interested in looking at breast, prostate, and colorectal cancer. And we were doing this work in Medicaid beneficiaries, both with and without HIV across 14 states between the years of 2001 and 2009. And I just want to take a moment to acknowledge Dr. Richard Moore. He's the person who, he and his team had this Medicaid data, and they were really generous and supportive of us using it. So in general, in what I'm about to present, we're identifying HIV and cancer incidence using ICD-9 codes, and we identify these on inpatient and outpatient claims. We use a pretty standard definition of 1 inpatient or 2 outpatient claims to determine that somebody has a given condition. And we're slightly more conservative than other groups. We require the 2 claims to be within 1 year. We also identify cancer screening using procedure codes, again, on inpatient and outpatient claims. Sometimes that can be a little bit tricky, and I will talk a little bit more about that in a few slides. So the first study we did was looking at breast cancer incidence, and we did this by age and race ethnicity. Again, this is in 2001 through 2009. And so I'm showing you here just kind of what our study population looked like. So we have a lot more women without HIV than with HIV. In general, our women living with HIV are more likely to be Black, and they are in general older than our women who are living without HIV, okay? And so this work was led by Monique Carr, who was a doctoral student in our department. She recently graduated. And so what Monique found, first of all, was she looked at the incidence of breast cancer overall, and she stratified this by age. So why do we stratify by age? She was really interested in trying to tease out premenopausal from postmenopausal breast cancer. So we can't know this in this data, but we used an age cutoff as sort of a surrogate marker. And you can see that among our women who did not have HIV, the incidence is quite different. As we would expect, it's much more common in older women than in younger women. So when she compares breast cancer in women with and without HIV, this is what she sees over here. And you can see for older women, the answer is quite similar to what we see in prior studies. And that is that women living with HIV were much less likely to have breast cancer than women without HIV. So that's very consistent with prior literature. But what was also interesting is that she saw that that difference was really attenuated among younger women. So the difference that we see in the literature in general may be reflective of breast cancer incidence in older women, and that's where it's more common, but it may or may not be the same among younger women. So the next thing we did was look at colon cancer incidence. Okay, so again, I'm showing you here our beneficiaries with and without HIV. So our beneficiaries with HIV were more likely to be male. And again, you can see that there's a little bit of difference in the age distribution. So our beneficiaries with HIV tend to be a little bit older, and they're less likely to be white. And so I'll just take a moment to, again, make a case for stratifying by age for this analysis as well. So this is a map of the US, and our states that are included in the analysis are in purple. And what I'm showing you here is colorectal cancer incidence in people less than 50 years old across our 14 states. So as many of you might know, colorectal cancer incidence among younger people, so those below the age of 50, has been increasing. So it's still more common in older people, but it's been increasing in younger people. And we see some variability in how common that is across the states in our analysis. So we wanted to stratify by age. And again, this work is done by Hopkins. And so what she looked at was the cumulative incidence of colon cancer among people who are 50 and older. I'm showing you here males and females. And what she observed in this analysis was also quite similar to what other people have seen. So this is actually the probability of not having colon cancer. And so you see that people with HIV had less colon cancer than people without HIV in this solid line. And the incidence was pretty similar among females, but again, very consistent with what prior people have reported. However, she saw a different pattern when she looked at people less than 50 years old. So when she looked at people less than 50 years old, she saw that people with HIV were more likely to have colon cancer than people without HIV. And she saw this pattern for both males and females, but as she kind of drilled down and looked at different strata of the data, which I'm not showing you here, this was really driven by males and it was really driven by white males. And so we found this pretty interesting. And so she followed it up with her next analysis in which she looked at the receipt of colonoscopy or sigmoidoscopy, again, stratifying by age. And so when she looks at people who are 50 years or older, at this point, we're expecting that this could be for screening purposes. Now, in the era of this data, the coding between 2001 and 2009, indicating that a procedure was specifically for a screening versus a diagnostic colonoscopy, it's not great. And in fact, when she went back and looked at symptoms associated with these procedures, pretty much everybody who received a colonoscopy or sigmoidoscopy in our data also had at least one symptom recorded. So it's very hard, just keep that in mind. We can't really distinguish which of these were for screening purposes versus diagnostic. But what she sees in general is that when she kind of adjusts for just age and state and basic factors, there wasn't a huge difference in receipt of colonoscopy or sigmoidoscopy between people with and without HIV. And when she adjusted for comorbidities, which we know in the general population, more comorbidities is associated with an increased likelihood that you'll receive a colonoscopy, she saw that people with HIV were less likely to receive a colonoscopy or sigmoidoscopy than those without HIV. And again, for screening purposes and cancer screening in general, other people have reported that people with HIV may be at less likely to receive cancer screening in general, but there's not a lot of data out there on it. She saw a very different pattern, though, when she looked at colonoscopy or sigmoidoscopy among people who were less than 50 years old. So again, at this point, we don't expect that any of these would be for screening purposes, because during this period, they wouldn't have been screening young people or people less than 50 for colon cancer. And so she sees this very different pattern in which people living with HIV were much more likely to receive a colonoscopy or sigmoidoscopy than people without HIV. And this was attenuated a little bit overall, or kind of a lot of it overall, when she adjusted for comorbidity, but it remained among her males. So among males stayed more likely to have received a colonoscopy or sigmoidoscopy if they had HIV as compared to those without HIV. And this is kind of consistent, we think, with her finding for colon cancer among people less than 50, and in particular among males less than 50. So why might this be? So part of this could be that some of the drugs that people were taking for HIV during this time period had side effects, and some of those side effects are GI related. There could have been other sort of comorbid conditions that in general lead to people getting more diagnostic workups. And so that could influence our colon cancer incidence in a couple of different ways. One, it could lead to early detection of colon cancers because you're having this procedure. Also, if you're in there and you're having a colonoscopy and there's a precancerous lesion that's removed, that can impact your risk of colon cancer in the future. So this data is, again, in a certain period between 2001 and 2009. And what we're hoping to do is to look at this over in more modern data to see whether or not this pattern holds. Okay, so then now what are we doing? So we like to call ourselves the Medicaid Study. So this is an expansion of our Medicaid and cancer studies. And so this is funding that we received to expand our data to include beneficiaries up through 2017. So this is going to include a conversion to ICD-10 data. And right now we're processing our data up through 2015. And just to give you a sense of how much data this is, I'm showing you a table here that shows you all of our states that are included. And these are unique individuals who are 18 or over. So this is with no restrictions in terms of enrollment or any other kind of criteria. But just to give you a sense, we're looking at around 76 million people. So it's a lot of data over a lot of time and a lot of space. So our goals in this project are to assess all cancer incidents, not just the non-AIDS defining cancers we've been talking about in the past few slides, among people living with HIV. We also want to evaluate differences in cancer treatment and short-term outcomes after cancer treatment by HIV status, where we will be assessing the impact of a cancer diagnosis on HIV care. Brian mentioned earlier, there's also continuums of care for HIV. And so we want to see whether or not a cancer diagnosis impacts that. And then we're evaluating the impact of cancer diagnosis on age-related outcomes, including dementia, polypharmacy, and some other things. And we're looking at that separately among people who do and do not have HIV. So you all can stay tuned for our results in Medicaid. While we're doing this, I just want to say, we've continued to work on other projects, including Johns Hopkins clinical cohort, which we've mentioned earlier. And I just want to give a shout out to a little study that we've done there for prostate cancer. So this is with Philip Purcell and Mark Markowski. So Dr. Markowski is a medical oncologist at Hopkins, and he was really interested in whether or not factors associated with HIV might predict prostate cancer specific mortality. What we're showing you here is prostate cancer disease-free survival. So these are men who were treated, and we're looking at whether or not their disease came back or they died of that disease. And so this is a small study. So this is, just under 50 men. But what I'm showing you are outcomes for men who largely had early stage low-grade disease and were treated by surgery or radiation, and their disease-free survival by indicators of HIV status. So by viral load and treatment status and by CD4 count. And what we found, and I'm not showing you like the fine details here of categories, but there was really no difference. And so the outcomes for men by these factors were the same. And so Dr. Markowski tells us that's good news because it puts more information out there that if you have a man with HIV who has early stage or early grade, very treatable prostate cancer, then you can be confident that, or at least increase confidence, because we do have a small sample size here, but some evidence that they should do as well as men without HIV. So just to say, but wait, there's more. We also want to shout out Jacky Rudolph. So Dr. Rudolph joined us, I guess, within the past year or so. It's kind of hard to tell time. And she's fantastic. And she has a CFAR grant to link our Medicaid data to cancer registry data. And so she's looking at doing this for California and Texas. And that will enable us to look at other things that we can't look at in claims data alone. Part of that is delays in diagnosis by HIV status, potential differences in stage diagnosis, and differences in receipt of treatment. And so we're really excited about that project. And then also Philip, who I just noted, I've been very silent on prostate cancer, which many of you know I spend a lot of time working on. So Philip is finishing up his dissertation on prostate cancer screening and incidence by HIV status. So again, I'm going to ask you to stay tuned because he will be telling you about his results sometime in the near future. And then finally, we have a new project that's under review to investigate the impact of COVID on HIV care. And this project would include access to cancer care. So we're really excited about that because if this is funded, we're going to expand to 27 states and have data up through 2024. So lots of opportunities to do lots of great work in that data if we get that. And so finally, I think Brian and I would both just like to acknowledge all the people who've worked on these studies and our funding. It's been a really fun team and it seems to keep growing. And so, yeah, we're excited to share it with you and happy to take any questions.
Sorry about that. I just turned on my mic. I think we're a small enough group that people could ask questions. Well, thank you so much. I'm not closing the discussion. I'm just offering a comment and then I'll ask a question. Thanks so much, Bryan and Corey, for introducing us to this topic of cancer in HIV, and you've really investigated a number of spots where we could intervene. So I was wondering if you, as an intervention and as a conclusion out of all of this research, would you recommend that HIV providers insist to their patients that they get screened and, to try to get, well, we always want this, but to get earlier diagnosis being that it's most important here?
Yeah, I mean, I don't know, Bryan. I think yes, I think it's going to be different depending on which cancer you're looking at and what kind of screening. So again, stay tuned for Philip and PSA and whatever patterns he might see. I don't know, Bryan can probably comment in more detail than I can, but at least anecdotally, I know some of the physicians who treat people with HIV here have shared that they are constantly encouraging their patients and to engage with cancer screening, and that it is a focus and a priority for their care. I don't know if that's universal. We're obviously at Hopkins. And so I don't know, Bryan, if you have other thoughts on that.
Yeah, I would agree that I think they are trying to push cancer screening. I think the issue is the uptake part, right? I mean, it's really hard to get people to come back in, right? I mean, getting colonoscopy is not an easy thing, right? At the end of the day, right? You got to prep for it. You got to take some time off from work. These are people already that have a lot of struggles, just being in general low income, right? Because HIV affects people of lower income disproportionately. And so, there's just a lot of challenges in terms of that, as well as other sort of, challenges of other comorbidities that are going on in this population that are not trivial, other chronic diseases and factors.
Yeah.
We have a question in the chat. It's from Sita, and she asked, can you speak a bit about cancer burden among key populations vulnerable for acquiring HIV? And in terms of populations affected, do cancer burden and HIV burden go hand in hand?
Yeah, so I think some of this would be really hard to tease out, like the transgender population, just because even though there are some cohorts of people with HIV and transgender, they are very small sample sizes, right? And so that it's very hard to evaluate the risk of cancer. Even some of the larger cohort consortiums like NA Accord with 100,000 or 110,000 individuals or so, right? It's hard to actually look at single cancers and try to evaluate cancer burden, even among these larger groups, especially once you want to start looking at other things like in terms of other vulnerable populations, in terms of MSM and transgender, and even breaking it down by race, it becomes hard, right? The whole, you can only split your sample size so many ways, in other words. And I think that's why, Dr. Joshu and I were really excited to go this route of Medicaid, is because it finally gives us a large sample that we can start partitioning things a little bit more and looking into not only age data, but also race and sex. Obviously, we're not going to have transgender in as a data point, so we're not going to be able to talk about that. We're not going to be able to talk about MSM. So those are going to be a little bit harder things to tease apart in these data, or if not impossible.
Yeah, I would agree. And also just to say, like, I think too, in the cohorts that the experience of men is better represented than the experience of women with respect to cancer. So that's another thing that we're hoping to illuminate, that we do have more women. And then also, these are low income people specifically, which I think also, there's a different risk there for than some of the other data sets that you see out there with privately insured people who have higher income. And so their experience may be very different than the experience of people on Medicaid.
Well, this is quite a coup having your Medicaid data now linked to cancer registry data. I'm anticipating the outcome of that project. So that's wonderful for you all. We'd love to hear more in the future about what you're discovering. Any other questions?
Yeah. Hi, Norma. So it's Elizabeth, Corey, Bryan. Thanks for speaking today. So I recall that there was an increase, no, actually it decreased risk, inverse association. Let me say it differently, that the incidence rate in those with HIV for prostate cancer was lower than anticipated. And that was work Eric Engels, actually Meredith Shields, who was a doctoral student in our department, led that work years back. It looks like the results are different today. What's different?
Different, which results are different?
So it looks like, so prostate cancer is going to be one of the largest burdens, but is the risk or rate in the contemporary era in those living with HIV still lower than would be expected for those who don't have HIV, all else being equal? Looked like that it shifted, that it changed. Am I
Yeah, I think the distribution among people with HIV has shifted due to like the things that Bryan talked about.
Aging of the population
and reduction in AIDS defining cancer. So prostate cancer is now more common among people living with HIV, but so far the data suggests that compared to the general population, the risk of prostate cancer is
still lower.
Still lower. That's right. But it seems like they still have depending on where you're looking, may have a higher risk of later stage disease, again, depending, and may have increased all-cause mortality, which argues a different sort of maybe some access to care might be playing a role. But yeah, as of now, it looks like
it's still the same. So it's still the same impression.
But the burden among that population. So in terms of the importance of prostate cancer for the population of men living with HIV, that might shift for those men, prostate cancer becoming more important, but relative to the general population, they don't seem to be at higher risk. And that could be like due to hormone. I mean, that's what people hypothesize.
Right.
Whether or not that's the case, we don't know. I think one of the things that working with Mark Markowski has been pretty interesting is he's like been thinking of different ways that could contribute, and different sorts of things and ways that people are treated for HIV. And so having lower testosterone, maybe a higher risk of having clinically low testosterone that requires testosterone replacement therapy. And so different sorts of things that go along with HIV that might make their prostate cancer risk lower.
Right. So Alan Meeker's on, I'm going to do a long rifles down coffee thing. Meeker. Hey, Meeker. So, people who are immunocompromised, immunosuppressed have obviously altered immune responses. One of the areas that you've been studying, and our team together, Corey, you're part of this too, is looking at the immune environment and how that may influence prostate cancer risk. But in people who maybe I don't know if they've reduced inflammation, but at least reduced immune response, could that be an explanation for the lower risk of prostate cancer? So Meeker, you want to put your 2 cents in about that?
But you'd think it would be more of a generalized phenomenon, right, across many different cancer types. And it didn't seem like that was the observation.
Right, but doesn't the prostate have like a weird CD4, CD8 balance that's different than other organs?
Oh, yeah, it is strange, actually.
Yeah.
And it's also one of these quote unquote immunologically cold cancers when they do develop. So, that's an interesting idea.
we'll just write that down. There's nothing more to say at this moment. We're going to think that one through. Yeah.
It's interesting. I mean, we could definitely look at the CD4, CD8 sort of ratios among people with HIV, you know, who develop prostate cancer versus not, maybe. Yeah. I mean, we don't have a huge sample size in the clinical cohort. I mean, we're talking about 48 individuals. Right. So it becomes a little bit hard to start teasing things apart too much.
Sure. And I'm not actually thinking circulation, right? I'm, circulating balance. I'm actually in the tissue. Right. Yeah. But I could see that there could be a change in the balance in the tissue as well, but it may not necessarily be correlated exactly with what's going on in circulation.
Yeah.
Yeah. Sure. Something to think of. Let's write that down and think about it. Right. As a potential explanation for the reduced, like lower than expected risk for prostate.
Yeah. I think I would check with somebody like Chuck Drake or Angelo DiMarzo. They'll probably have a better handle on that.
Okay. Any other questions for our speakers today? Hearing none, I'll just say thank you again to all of our speakers. Really appreciate you providing this seminar. As I mentioned, it is recorded, and we will be having it available to a larger audience very soon. So thank you so much, Corey and Bryan.
Thanks for having us.
Bye-bye.
All right, bye-bye.
Bye, everybody.